A big hello to everyone. Thanks for joining us as we discuss another case from our emergency department. I hope you will enjoy and learn. A recent case at our emergency department was that of a 35-year-old male patient stabbed to the right side of his back, just next to his scapula. He was not doing well and unable to stand, and the X-ray had to be taken while the patient was lying down or supine. This caused some difficulty for the attending doctors, as it is unusual to diagnose a pneumothorax in this orientation. Even though the patient was relatively stable, his oxygen levels were low and had to be supplemented. Let's analyze why this X-ray posed a problem. First, let's look at the trachea, clavicle, and length of the ribs on the right-hand side. It indicates rotation of the patient in a slightly odd configuration. He is lying down but leaning towards his left, possibly because it's too difficult to lie on the right, and he is hunching and curling his rib cage, with the right starting to overlap the left. He was intoxicated, which makes it difficult for radiographers to keep a patient in the correct position. He was likely turning his head to face the right. This makes the trachea shift away from the midline. The rotation of the upper chest makes the right clavicle appear shorter, and the opposite clavicle longer by comparison. The same rationale can be applied to the ribs. The ribs on the right side appear slightly longer and are a bit lower than their counterparts on the left side. Intoxicated patients are common in emergency departments, and it can be difficult to keep them in the necessary positions for examinations and interventions. And consent also becomes an issue. It is often best to obtain consent from a relative accompanying them, or someone in a management capacity at the hospital authorized to do so. Another major issue is deciding if there is an associated head injury. The best way to check for this is to keep the patient in a neuroprotective position and reassess their level of consciousness at hourly intervals. This is especially true if they have a GCS of around 13 or 14, but without localizing neurology. No change or a decrease in GCS warrants immediate CT. Improvement generally means that an intracranial injury is unlikely. From personal experience, I've found that assessing the patient's pupils and their reaction to light at regular intervals is one of the best indicators you can use in a busy ER. If you are lucky enough to work in a setting where CT is done as part of routine workup for trauma, this would not apply. Unfortunately, the majority of the world's doctors do not have CT as an immediate option. Don't forget to listen to your support staff. Nurses, porters, radiographers, and the like often have much more interaction with the patients than you will as a doctor. You should be the kind of person they can feel comfortable coming to with concerns. You will find that listening to your colleagues' concerns and following up will often prove extremely valuable. Getting back to the chest X-ray. What may look like a large pneumothorax on the right mid-chest is the scapula. It is important to note its position, which also indicates the rotation of the patient towards the left. The actual pneumothorax can be seen just lateral to the inferior tip of the right scapula, and just medial to, and overlapping with the long tube-like artifact, which is an IV line. The other clue to the presence of an air leak are the patches of surgical emphysema, seen in the right axilla and left side of the neck. The compression of the left lung makes it difficult to see if there is a pneumothorax on that side. The presence of subcutaneous emphysema should prompt a CT scan for one extremely important reason. There was only one stab, and if it injured both lungs, it means the injury tract crossed the midline and could well have caused damage to structures in the mediastinum as well. Another thing to note is the hypervascularization of the right lung, as seen here, compared to the left, which looks relatively normal, making it less likely that the left lung is injured. The subcutaneous emphysema may also be due to this patient favoring his left side and rolling onto it. This means any leakage of air would track to that side due to gravity. In the end, an intercostal drain was inserted into the right side of the chest, and he improved. The surgeon felt a CT would be done if he deteriorated later. He was injured over the New Year's weekend, and, due to a large patient load, resources had to be managed properly. Working in semi-rural/rural areas often means weighing up the benefit to risk for certain investigations and interventions, as was done here. But ideally, he would have had a CT before any interventions. Here's a decision-making algorithm that an emergency doctor might use. 1. Initial assessment and stabilization. Primary survey. Follow the ABCDE approach: airway, breathing, circulation, disability, exposure. Airway and breathing. Ensure the airway is patent and assess breathing. Look for signs of respiratory distress, tracheal deviation, asymmetric chest wall movement, or reduced breath sounds on the affected side. Oxygen. Administer high-flow oxygen through a non-rebreather mask. 2. Confirm diagnosis. Clinical diagnosis. Based on history, such as trauma, and clinical signs: hypoxia, chest pain, subcutaneous emphysema, diminished breath sounds. Imaging. Chest X-ray, or if unstable, an immediate ultrasound may be more practical. Please have a look at our presentation on recognizing pneumothorax on ultrasound. It is linked in the description. 3. Emergency management. Needle decompression. In attention pneumothorax, immediately perform needle decompression using a large bore cannula, 14 to 16 gauge, in the second intercostal space, midclavicular line on the affected side. Follow up with chest tube insertion. Insert a chest tube, thoracostomy, in the fourth or fifth intercostal space in the mid-axillary line to evaluate air or blood. 4. Monitoring and supportive care. Monitor vital signs. Continuous monitoring of oxygen saturation, heart rate, blood pressure, and respiratory rate. Pain management. Administer analgesics as necessary. 4. Fluids, if indicated, especially in hypotensive patients. 5. Further investigations and management. Repeat chest X-ray after chest tube insertion to confirm correct placement and re-expansion of the lung. Additional imaging. CT scan if there are concerns for additional injuries. Remember, this is a general guideline. Individual patient management may vary based on specific circumstances and institutional protocols. Managing a pneumothorax. especially under challenging circumstances, requires skill, patience, and critical thinking. Keep an eye out for our upcoming videos on needle thoracostomy and intercostal drain insertion. Thank you for watching ER Mentorship Hub. If you found this video informative, please like, subscribe, and share your thoughts or experiences in the comments below. For more detailed information, check out the links in the description.